over the next minute or so. But I think in the interest of time, I think we can probably get started, and that way we're leaving more time for discussion. So welcome everybody. I'm Kate Champion. I'm one of the general surgeons here at the West Parry Sound Health Center, and I have an appointment, faculty appointment to NOSM as well. And I'm here presenting with my colleague, Dr. Foster, whose exact words were less ceremony, the better. To say hello. So I'll do you want to come wave, Ken? Say hi to everybody. There, Ken's there. So we're doing a presentation together on what we're calling general surgery PPE, poop, pus, and extremities, and focusing on tips and tricks for the primary care setting. We do have to do disclosures because this is an official rounds talks. I have a grant from the Northern Ontario Academic Medical Association for a frostbite project I'm working on, and then both Dr. Foster and I receive honoraria in support of this program from the Parry Sound Leg. So our learning objectives today, first off, we're going to talk about anatomy and physiology of common benign colonic and anorectal complaints and develop an approach to prevention and treatment counseling. We're also going to identify and describe indications and approaches to the management of subcutaneous abscesses and breast abscesses from a primary care perspective. And then Dr. Foster is going to take over and discuss diabetic foot ulcers and prevention and management, as well as identify and describe treatment approaches and common pitfalls in finger and hand trauma in the primary care and emergency room setting. So in true general surgery fashion, we are starting off today with poop. We're going to start by talking about benign colonic and anorectal disease. So I wanted to start by talking about the colon, and then we'll talk about the anorectal concerns. So starting out from a diverticular disease perspective, the diverticuli are predominantly in the left side of the colon, but you can see them throughout the colon. You may be familiar with what are often referred to as false or true diverticuli, meaning how many layers of the bowel are involved. And diverticular disease represents false diverticuli. So these are basically outpouching through the muscular layers of the colon at areas of weakness that are adjacent to perforating blood vessels. And they're predominantly in the left side of the colon because they result from higher stool pressures that are required to push along low volume and low liquid stool. And so this is what contributes to the left-sided prevalence. You can see them on colonoscopy, or you can see them on CT scans as well. So you may get a report from a patient for an abdominal CT, and they note diverticuli throughout the colon. And so that may be something that you see just on a report, which may or may not be of any clinical significance, depending on what you're ordering the report for. In terms of complications of diverticular disease, so having diverticuli themselves doesn't necessarily mean that you're guaranteed to have a problem. And the number or the size of the diverticuli also is not predictive of diverticular disease. Common complications that we see that you may already be familiar with are diverticulitis, which can be uncomplicated, meaning just inflammation of the colon, or complicated, meaning they're associated with abscesses or microperforations or a free perforation. Those are the patients that we take to the operating room presenting with generalized peritonitis. And so diverticulitis, commonly people would present with left lower quadrant pain. They may or may not have a fever. And then those patients with free perforation who need an OR would present with generalized peritonitis. You can also have diverticular bleeding. So this is typically presents as painless, large volume hematochezia or bright red blood per rectum. So, and this is more common with patients on blood thinners. And at the end of the day, diverticuli are not reversible. So once you have them, you keep them, and we basically just have to manage complications of diverticuli as they arise. Diverticulitis is often treated with antibiotics. Again, sometimes patients need an operation. And diverticular bleeding, often it's reversing the patient's anticoagulant and just waiting for the bleeding to stop. But sometimes we do colonoscopies on these people as well, both for diagnostic and sometimes therapeutic purposes. Overall, the biggest factor really is talking about prevention of diverticular disease. So again, once you have these outpouchings, you can't get rid of them, but you can hopefully prevent your body from making more. And that's through a high fiber diet, which we will talk about in more detail afterwards, later down in the talk. Constipation and diarrhea we commonly see as well. You will often get referrals for patients who have long-standing issues with constipation or diarrhea that don't seem to be getting better. Most commonly, the causes of this are insufficient bulk of the stool or insufficient water retention in the stool that makes it hard to pass. And the treatment here, again, is fiber. You will note that there is a theme that comes up with a lot of these benign anorectal conditions, that fiber helps quite a bit, because what fiber does is it treats the insufficient stool bulk issue and it helps retain water in the stool to allow that stool to pass easier. When it does that, it requires less pressure on the left side of the colon to pass that stool along. And so that's why you end up with fewer outpouchings or creation of these diverticuli, because the colon isn't trying to push against that pressure to have that the mucosa pop through that muscle layer at those areas of weakness. Having said that, as I'm sure many of you are aware, we also need to be aware that there are red flags for constipation and diarrhea or changes in the bowels that can be more concerning for pathology. So it's always good to start people off with fiber, but to have, yeah.
The slides aren't advancing. I think we have to.
Oh, the slides aren't advancing. Oh dear.
Have to share a screen differently.
Okay, no problem. Thanks for letting us know. We will exit and go back. Is that still moving, Kathy?
Yeah.
Great. Okay. Sorry about that little technical error, guys. Hopefully it continues to work. If it does not, please let us know so we can adjust it again. And so we were talking about constipation and diarrhea and red flags for early referral. So particularly if you have a patient who's had regular bowel movements their whole life, and then all of a sudden, especially if they're over the age of 50, they have consistent constipation and diarrhea that's not getting better over several weeks. That's something to be concerned about and may require an early referral. If the new onset of constipation or diarrhea is also associated with significant weight loss, is associated with new or persistent melena, hematochezia, or bright red blood per rectum, is associated with new and persistent localized abdominal pain, or if they have nocturnal bowel movements, those can all be signs of pathology, in particular colon cancer or inflammatory bowel disease. The nocturnal bowel movements are the inflammatory bowel disease component. So now we're moving on to chat about anorectal anatomy. So the anal canal is what connects your rectum to the outside world. It's a fairly short space, a few centimeters in length, but the anatomy is fairly complex. You've got the internal and the external sphincters, which are the muscles of control contributing to your continence, so your ability to hang on to gas or stool. And these muscles coordinate with the pelvic floor muscles, which also contribute to continence and the coordination of rectal evacuation and bowel movements. We have the anal crypts and glands that sit in between these sphincters, and sometimes they can get plugged and can contribute to abscesses or fistula formation. And we also have the hemorrhoidal plexus that lines the anal canal, that's both internal and has external components as well. The anal verge consists of the anoderm, which is the non-hair bearing skin of the bottom end between the anal canal and the hair-bearing skin on the bottom. And so we'll chat about these in more detail, particularly the hemorrhoidal plexus, as we move forward. So it is important. I always chat about this with the medical students, and I think it's important for all of us to recognize that the digital rectal exam has a number of things that we're trying to look at and think about, as opposed to just kind of going, stick your finger in, is there a mass? Yes, no. There are two components, really your overall inspection component and your palpation component. So when you're doing a digital rectal exam, I always like to start by looking on the outside, and I will often distract the buttocks to the side a little bit so I can make sure that I'm visualizing the anoderm well. So that helps you identify, can you see a small fissure in the posterior midline? Can you see any external fistula openings? You can identify any active external hemorrhoids or perianal skin tags, which are involuted old external hemorrhoids. And you can also identify other skin lesions. So that includes things like anal condyloma or other pigmented lesions or masses that might need biopsies, or a referral to your local general surgeons. And then the other thing is to, so once you've done your inspection externally, this is where you want to palpate internally. So a gloved finger with some lube. You want to start by inserting your finger up as far as you can within reasonable comfort for the patient. Do a circumferential exam of the distal rectum, and you'll also feel the prostate in males. You want to identify the top of that anorectal ring, which is the top of the sphincter complex, so where the internal and the external sphincter come together. And you want to do a circumferential exam of the sphincter complex as you're withdrawing your finger. And if you had a patient with a fistula, you might be able to palpate internal fistula openings, and again, you'd be able to palpate any masses. So I'm going through this because I think that by spending just an extra, not even kind of 10 to 15 seconds, just being conscientious of what you're looking at and what you're feeling, you can get a lot more information from a digital rectal exam as opposed to just, is there a mass or not? So then this takes us to hemorrhoids, and we're going to talk about external hemorrhoids and internal hemorrhoids. External hemorrhoids represent enlarged vessels of that external hemorrhoid plexus, and they can become thrombosed, and it's the thrombosed hemorrhoids that are typically very painful. They don't necessarily have to be painful, although external hemorrhoids are typically present as are more likely to present as pain as opposed to the internal hemorrhoids. And these are often the hemorrhoids that people will feel if they feel like they have perianal lumps when they wipe. They can present as blood on the toilet paper or in the toilet bowl or on the side of stool. If they're bleeding, they don't always have pain associated with them, but certainly if they're thrombosed, so you'll see this big purple angry looking thing externally, then they can certainly be painful. Ultimately, the treatment of these really is fiber, because you want to be passing regular soft formed stools. These can get irritated with both diarrhea or with constipation. And so fiber becomes the tool to moderate the stool and help these settle down. You can get pain control if needed, so Tylenol and Advil. You can consider short-term use of Anusol if they're painful, but I wouldn't recommend using it for an extended period of time because it can thin the skin. And if someone presents to your office with an acutely thrombosed hemorrhoid and it's within the last 72 hours, then you can consider excising the hemorrhoid in its entirety or expressing the clot from the acutely thrombosed hemorrhoid. You often hear that described in the literature. But once we get past that 72-hour mark, they're usually starting to involute anyway, and making an incision is also going to be painful. So then you kind of have to weigh those risks and balances of, yes, I can make a cut in your bottom end, but you're just trading the pain of the hemorrhoid that's going to get better on its own anyway for the pain of me making a cut in your bottom end. And I find when I have that discussion with patients, for the most part, they're okay with managing with pain control, and inevitably things do get better. Although these are quite painful, and unfortunately, a lot of people don't present until they're like 5 days out, have been in significant pain for that amount of time, and it takes time to let things settle down. From an internal hemorrhoid perspective, you may have heard previously that there are 4 grades of internal hemorrhoids. These help us understand the size and more importantly, how much they prolapse or come out of the anal canal. Grade 1 hemorrhoids are internal only, so we just see them right here. They get enlarged, but they don't necessarily, you wouldn't see them coming out in the office, but these patients often present as painless, bright red blood in the toilet, maybe some drops to turn the toilet bowl red, maybe the occasional clot in the toilet bowl. Then we have grade 2 hemorrhoids. These hemorrhoids will prolapse when the patient is pushing to have a bowel movement, but then they go back in spontaneously. So this patient isn't necessarily going to feel a lump at the bottom end, but again, they're going to have pain. They're going to have painless blood in the toilet. The grade 3 hemorrhoids, it doesn't quite show it on this picture, but these come out and they typically need to be manually reduced. So the patient may describe, yes, I feel like there's a lump that comes out every time I have a poop. There's often some blood and I can push it back in with my finger. Grade 4 hemorrhoids are hemorrhoids that are permanently prolapsed. So they're out there and you see them when you examine someone. They're often contiguous with the external hemorrhoidal plexus at that point as well. So you just see this big hemorrhoid that seems like it's coming out from the anal canal and you can't push it back in, and the patient is unable to push it back in. Typically, when you have grade 4 hemorrhoids, it's not uncommon that people have multiple hemorrhoid columns that are involved. So there are typically three areas in the anal canal that we would commonly see these. And oftentimes these patients can have big angry looking circumferential hemorrhoids. I think an important principle to recognize with both internal and external hemorrhoids is that hemorrhoidal tissue is a normal anatomical part of the anal canal. And so when we talk about doing either banding or a hemorrhoidectomy, what we're really talking about is debulking that tissue. There is no way for us surgically to remove it entirely. If we did that, I would actually worry that we'd be creating scar tissue that would narrow the anal canal to the point that that person then may have trouble passing the stool because of the scar tissue, and we don't want that. So it's about finding that balance. But ultimately, I think it's important for patients to know that hemorrhoids are basically an irritated part of their normal anatomy, and that it's important to treat the underlying cause of the hemorrhoid in order to prevent things from coming back. Because we could do banding multiple times, we could do multiple surgical excisions, but at the end of the day, if people aren't eating enough fiber, again, you'll notice the theme, fiber is important, then they're going to run into trouble and have recurrence. This then takes us to anal fissures. These typically are in the posterior midline. You see them visible when you have the anoderm on stretch. You'll see the distal part of it. And they usually start acutely as a tear in the mucosa, and they can progress to chronic fissures, where at that point you can see exposure of the underlying internal sphincter muscle fibers. And you also see development of what's called a sentinel skin tag on the outside, or a hypertrophied anal papilla on the inside. These typically occur with constipation, but they can also occur with diarrhea. And this patient, in contrast to the hemorrhoid patient, is presenting with sharp stabbing pain and usually a small volume of blood on the toilet paper or on the side of the stool. Again, the primary method of treatment really is fiber. That's key. But then when you get to this chronic stage, that's when we also need to consider nifedipine or other topical treatments, and sometimes surgical treatments as well. So as you've now heard me say multiple times for pretty much everything we've talked about, fiber is the answer to pretty much everything. We should all be aiming for 25 to 30 grams of dietary fiber per day, but most of us in North America don't come anywhere close to that. And so we need to do some kind of supplementation with fiber. I find that when I'm chatting with patients, there are some patients who find it easier if they kind of take their fiber as if they were taking medication. Maybe they take other medications once or twice a day. And in that case, they can take a couple of heaping tablespoons of psyllium, which is about half of their fiber. And they can take that mixed with juice, mixed with yogurt, sprinkled on their breakfast, however they'd like to do that. And then I have other patients who say, oh, I really struggle with taking medications, I never remember. And if you have a bowl of bran cereal, which typically contains psyllium, with fresh fruit on it for breakfast, that gets you approximately half of your daily fiber intake right there as well. And then you make up the rest in terms of general high fiber choices throughout your day. So making sure you're eating lots of raw fruits and vegetables. Green leafy vegetables are great. The raw vegetables have more fiber than when they're cooked. You want to make sure you're picking high fiber bread instead of white bread, brown rice instead of white rice, high fiber or whole wheat pasta instead of regular pasta, and legumes like lentils, chickpeas, black beans, kidney beans are all great sources of fiber. So that's generally what I encourage patients to do. If they haven't been eating a lot of fiber and they need to build up a little bit, if you just go from eating not very much fiber to 30 grams of fiber per day, most people find that they have some bloating and some discomfort. So I usually like to warn people of that in advance. Otherwise, you have people coming back saying, I have an allergy to fiber. I have bloating and gas. But as long as they're working up slowly, then most people are able to manage that and adjust. And if you warn people in advance, then they're expecting it and it's not a big surprise. Usually takes about a month, I think, for everything to settle out. What do you do when fiber isn't enough? There are always a group of patients who maybe they're just not taking their fiber, they're refusing it, or they are, and they're still having trouble, particularly with constipation. This is Dr. Foster's recipe, and I like it too, with the PEG, which is pretty gentle, and you do a scoop for every day you haven't had a bowel movement. So if you haven't had a poop for a day, you get 1 scoop. 2 days, it's 2 scoops. 3 days, 3 scoops, etc. But then if you're getting into the like 4, 5, 6, 7 day range. You can also get people to do 2 liters of peg light, so half of the big jug, just kind of as a gentle prep if they're really backed up. In general, I think it's better to avoid long-term Senecosh or stimulant laxatives, just because that puts a lot of stress on the bowel and then it's not able to contract normally. So in terms of my key summary points for this, the answer is fiber. When it comes to preventing diverticular disease, the answer is fiber. Managing constipation and diarrhea, start with fiber. Oftentimes it fixes it. Primary prevention and treatment of hemorrhoids is often fiber as well. I have to say, outside of the grade 4 hemorrhoids, when it gets to that stage, you pretty much are going to need an intervention, usually with surgery. Even grade 3 hemorrhoids, I am amazed at the improvement that I see with people who are able to start on fiber and stick with it, sometimes to the point that their hemorrhoids shrink and they don't need an intervention. And certainly it prevents it from coming back if they do get an intervention. Primary prevention and treatment of anal fissures are also fiber. So the number one question for your patients with any of these issues is, have you tried increasing your fiber intake? Because that's often going to help. So at this point, we're going to take a short break for questions before we move on to abscesses. Any burning poop questions out there? Hopefully you don't have burning poop. If you do, you probably need fiber. It wouldn't be a general surgery presentation without a poop joke. All right, I think I'm just looking in the chat. I think slides and learning objectives. Okay.
Yeah, there's no questions yet in the chat, but if anyone has a question, they can unmute.
All right, well, we'll move along, but certainly post any questions you have in the chat, or feel free to unmute at any time. We're happy to chat. So we're moving on to abscesses or pus. We're going to stick with the subcutaneous and kind of skin-based abscesses, and we'll talk about breast abscesses. Perianal abscesses are a whole other thing, so I've left that, but we can certainly chat about that at the end if anyone had any specific questions about that. General principles for abscesses and pus is that antibiotics are insufficient to treat abscesses. So there are very few cases that you use antibiotics. I'm going to talk about what those exceptions are, but in general, antibiotics aren't able to effectively penetrate that abscess cavity. And so people are taking antibiotics that can't actually get into the spot where they need it to resolve the problem. In general, the key principle of all abscesses is drainage by unroofing it, and you want to remove a piece of skin so that the cavity drains sufficiently. All of that pus drains out so it doesn't sit there and continue to fester, and then the area is going to heal by secondary intention. If you only do a straight incision, then you worry that that incision just heals back together and then things reaccumulate. Or if there's a lot of debris, so in particular, this is the setting of something like a subcutaneous abscess, then if you don't pull the capsule out, or at least parts of the capsule, then it continues to make additional debris that's not drained, and again, it won't heal properly. So ideally, you want to remove skin, and then you want to get all the gunk out inside, including if it's a sebaceous cyst, you want to get the cyst out, or the cyst capsule out as well. Common causes of subcutaneous abscesses are infected sebaceous cysts or glands, IV drug users from injection sites, infected bug bites, or hidradenitis. But hidradenitis is that specific entity where you're seeing multiple tracts and abscesses in the intertriginous fold. So these are your axilla or your groin, and they have a very characteristic pattern of pits and tracts that you would see. The treatment of all of these things is ultimately drainage. If you're unsure whether or not there is a collection, and I think this happens more commonly, or certainly I see it more commonly in the IV drug use population, where you're trying to decide, is this cellulitis or is it an abscess? You can find the most indurated area where there seems to be some underlying bogginess or fluctuance. And you can consider then aspirating with a large gauge needle, like an 18 gauge sharp needle, with a bit of local, or you can do even a small incision or a punch biopsy. But ultimately, the primary treatment of this entity is drainage. Some of the common pitfalls that we see and the pearls to resolve them. One is that we'll see people coming in who have been put on an antibiotic and as they're waiting to see us in surgical clinic. Or it's been, is this an abscess? We're not sure. They've been on an antibiotic for a week or more and their abscess persists. And this is because, as we mentioned previously, antibiotics aren't sufficient to actually treat this. And so they need incision and drainage. And realistically, for healthy patients who don't have a lot of significant overlying cellulitis or surrounding cellulitis associated with the abscess, drainage is enough. That gives you your source control, and no antibiotics at any point are required. The other things we see, which I mentioned before, is you have recurrence after just a straight cut has been made in it, or if the inside debris, like the cyst capsule, hasn't been removed, then things can either reaccumulate because they close back over, or they continue to fester. So the key thing to correct that is to make sure that you're actually removing skin to ensure that everything drains and that everything is encouraged to heal by secondary intention from the inside out to minimize the chance of recurrence. An easy way to do this, Ken and I have been increasingly loving the 5 millimeter punch biopsy, because at the end of the day, you don't even need a scalpel. In the primary care setting, you're maybe thinking, well, we have all the surgical trays and tools in the hospital. You may not necessarily have the big trays that come in the emergency department with all of the various tools, but that's okay. You don't need them. If you have a 5 millimeter punch biopsy and a dressing tray that has the little forceps in it so you can pull stuff out from the inside, that's all you need. And those are things that are in most, if not all, of our primary care clinics. With the 5 millimeter punch, they're great for most sebaceous cysts. You can often just remove the contents and then parter all of the capsule through that space using the forceps. For hidradenitis patients, generally this is the recommendation, as opposed to a wider debridement, is unroofing and then ultimately a referral to dermatology for medical treatment. And at the end of the day, because you've removed that skin, you don't need a suture or a drain. You just leave it open and you avoid the painful packing that can go along if you pack it. A lot of these, as long as you've unroofed it, you've appropriately drained the pus, you've irrigated anything else out, then that's all you need to do, and it's going to heal by secondary intention. This also helps optimize our local clinical resource use and our patient wait time, because then if you're able to do this in the office, they don't have to go to the emergency room. You're not trying to get a hold of the on-call surgeon or sending an urgent referral, hoping with your fingers crossed that they're going to be able to be booked in for clinic at some point at the end of the day. And so this is the way, again, you just resolve the problem, and this patient doesn't even need any antibiotics. For larger, particularly large sebaceous cysts, the other handy thing about punch biopsies is you can use them multiple times. If 5 millimeters is not enough, that's okay. You can just use it again and again and again. And so that, again, that's sufficient that you can do complete drainage. And again, you don't need a scalpel. All you need is the punch biopsy and the dressing kit with some saline. You're good to go. When do you consider leaving a drain? Because you may see sometimes, particularly with notes that you may get from myself or Dr. Foster, that there are times when maybe we've left a drain in. This would be something to consider if you have a deeper abscess than a simple skin appendage, or the cavity is more than 5 centimeters in diameter. That's the point where I start thinking, maybe a drain is going to help just ensure that things close down around it. If you are going to use a drain, there are some technical things to consider in making sure that the drain is going to be functional. And again, if you're doing this with a large sebaceous cyst, you still have to try and get part of the capsule out, because just expressing the contents, leaving the capsule in place and putting a drain in, it's still going to make extra keratin and gunk, and it's not actually going to be able to heal because that cyst capsule is still in place. What I like to do with drains, you can do just a strip of the silicone Penrose, or I like to kind of cut one side off of it and turn it into a little J shape. So not just leaving it as a tube. If you leave it just as a tube, then all it can do is wick stuff out from the very bottom where the opening is. Whereas if it's a J, you're kind of making a little channel that it has a way to come out all the way along the length of the drain. And I like the little J because I find it helps prop it open to ensure that it drains. If you've put a drain in, you want to suture it in place with a big loose suture. Nylon is great. You go through the skin, through the drain, through the skin on the other side, and then through the drain above your last stitch. So you've got 2 nice stitches through the drain, 2 nice stitches through the skin, and that'll keep it in place. And generally, I usually like to leave my drains in somewhere in the 5 to 10 day range, or at least you want to make sure that the drainage is coming down and that you've started to have some of that healing by secondary intention around the drain. The reason I would use a drain for a larger cavity is really to make sure that it drains well and you end up with good healing by secondary intention and a much smaller hole by the time you're taking the drain out, and then the patient's body will take care of the rest of it. So these are some of the rules and general principles around abscesses, but what are the exceptions? Because there are always exceptions to the rules, and it's important that you know what those are. One important exception to the antibiotic rule is immunocompromised patients. So these include patients on immunosuppressive drugs like chemotherapy, your type 2 diabetics, or your type 1 diabetics for that matter, all of your diabetics, your HIV positive patients, particularly if they're not sufficiently treated as an outpatient. That often goes along with your IV drug user population. And I also kind of think twice about the smokers, particularly the heavy smokers. If there is some overlying cellulitis, I might be inclined to put them on antibiotics just for a few days. But this is antibiotics in addition to incision and drainage. So that primary principle of incision and drainage doesn't change, but you're giving them some extra support with the antibiotics to make sure everything heals well and the infection doesn't spread, because this patient population is at higher risk of severe sepsis or a necrotizing soft tissue infection if they have an abscess that's not drained. As a result, it's also important in this patient population to be very proactive about ruling out pus if you have an area that's suspicious. So again, if you're trying to answer that question for yourself, is this cellulitis or is this an abscess that's brewing, you can consider a needle aspiration, a small stab with a scalpel, or a punch biopsy to try and unroof something. Because at the end of the day, a 5mm punch biopsy is going to heal well in most people. You're not going to lose a whole lot by trying. If you get a whole bunch of pus out, great, and then you can always open it up bigger if you need to. But it's a nice way to explore that, again, doesn't require too many tools. The other exception, and this is the exception to the straight incision and drainage rule, is breast abscesses. They do need drainage, but it's preferable to do it as a needle aspiration because these patients are at risk of developing a milk duct fistula if you just use a scalpel and you take out a chunk of skin, and those can be really difficult to heal and chronic and ultimately not heal. Imaging is also critical before just going ahead and draining these, particularly in patients who are over 50, because you want to make sure that there's no underlying malignancy. Mammography can be painful with this, so it's good to start with ultrasound. And you can order an ultrasound guided needle aspiration through radiology. Our radiologists are able to do these on Tuesdays. However, if your patient presents on a Tuesday or a Wednesday, it's probably helpful to send them to Emerge, we can at least do the ultrasound. They can be seen by the surgeon, and oftentimes we can do a bedside ultrasound drainage with help from the ultrasound techs. But again, you need the imaging first, because if there's anything suspicious for a malignancy, then you have to treat it as such. Another entity that can present like a breast abscess is periductal mastitis, or you may have heard it referred to as Zuska's disease, which is recurrent abscesses that occur at the edge of the nipple areolar complex and just under the nipple. These are typically in smokers, can be seen in both men and women. And ultimately, the treatment for that isn't actually recurrent drainages, but it's really smoking cessation and antibiotics. So just something to keep in mind, that the immunocompromised patients are the exception to the antibiotics rule. The breast abscesses are the exception to the incision and drainage rule. So at this point, I'm going to hand it over to Ken, who's going to talk about extremities in extremis.
Okay, diabetic foot infection is probably our biggest problem. And of course, the tight control is important. The most important thing is to be conscious of the lack of sensation and the feedback that's lost, protective feedback. So patients should be taught to look every day at their skin to look for those things, redness, warmth, swelling, and pain or tenderness. Using the back of your hand is often a better way to feel for warmth. And calluses are always clues that need to be looked for. The big component, like fiber in the other part, now it's pressure modification. And that's where we spend time making pads. You can send them to the orthotist to get special fancy boots. They tend to cost a lot of money. So we use a lot of closed cell foam, which is firm, and it doesn't absorb water. It does tend to collapse eventually over time, but you just have to design something that'll fit firmly without sliding around, and cut out the pressure point so you redistribute the pressure around it. And that really is probably the single most effective thing we can do, especially for weight-bearing related ulcers. Now, on the toes, there are some deformities that give pressure points. So you can have excessive extensor tone, you can have hammer toe, claw toe. I haven't shown pictures there, but the point is these arise because of imbalance in the sensory feedback controlling the muscles. And so you get these deformities that can be, in many cases, corrected with a small tenotomy. And I find that really works in a lot of cases. I'm not proposing that you do it, but be aware that it is a real benefit. In the most difficult cases, the sort of short-term most effective go-to would be a full contact walking cast, which basically takes all of the dynamic gait, the shear and friction component in it, and redistributes the pressure more effectively. It has to be molded, and it takes me half an hour to make one, so they're not easy. The orthopedic clinics, he says, oh, well, why don't I just do one every week, as a cast tech. Well, we don't have that, and I can't offer that kind of a service, but it does have to be changed fairly frequently because they get messy with pus, the full contact cast that's on for any length of time. But once you get it healed up, this kind of image of that's more like a prosthetist, a fully trained prosthetist, not someone like Marcel who makes orthotic boots, but this is a very expensive custom designed device, but that's the long-term solution. Okay, the other problem we see all the time are these toenails that are caused by fungal infection. And I always get frustrated because, in my opinion, all of these antifungal agents are a bit of a scam because they don't work. They can work in the short term, but the damage is done in the sterile matrix. And once that is scarred, you can never get a normal nail again. Over the years, I have narrowed down my menu of options to two things. For the big toe, I do a germinal matrix excision in older adults, and in young adults, it's usually just an ingrown toenail. That's not fungus. That's another problem. You can use the fancy onychomycosis terminology, but in those, I do a wedge ablation, but you have to get the germinal matrix component of that. The older adults, it seems aggressive to take the nail permanently, but that's really the only logical thing to deal with these that are painful. If it's not painful, not infected, well, you don't need to do anything. But anyway, that's the option menu that I give. This is an image of germinal matrix excision. So you lift up a flap, and I use sharp dissection, and you scrape off the cortex of the bone so you don't leave any remnant behind. Because if you do, it's a bit of a problem. For the other toes, the small toes, the distal phalanx is so short, and it's very difficult to take out the germinal matrix by itself. So the only thing I offer is to disarticulate the distal phalanx. So it makes the toe, a few millimeters shorter, but they have no nail complex or distal phalanx. The one thing about nail bed injuries, and every once in a while we see this kind of missed. If there's any injury to the nail bed, you can fix it, and that's neither here nor there. If you can, fine. If you can't, just splint it. But the most important thing to make sure is that you do not allow the eponychial fold to sit on the germinal matrix, because it'll scar down, and then it'll be a permanent deformity of the nail. And I've tried to show a little diagram there. You can put a suture across more distally, right across the top of the nail to hold it in. There are different ways to do it. But often with these injuries, there's a crush injury or laceration, table saw across the paronychial folds on each side. So the best way is just to take, even if you don't have the nail, if you have the nail, that's ideal. Just scrape off all the loose tissue and slip it into the fold, and then make a suture. It's kind of like a mattress suture. You can see there where you go up underneath to pull it up and hold it in place. Paronychial infections are quite common, and this is a way of treating the ingrown toenail problem. The reason I put the picture there is basically to illustrate how well a toe can do, even when you take away that much of the skin right down pretty much to the bone there. You don't do anything to the actual nail bed. Here you can still see it's curved around. This is probably an older adult, I don't know. But anyway, the point is that a large deficit of skin can heal very nicely, and it really is as effective as doing the wedge ablation. It's just this takes weeks to heal, so I don't really like doing it. But if you have a paronychial abscess, a 5-millimeter punch is good enough to drain it and open it up. You can call it marsupialization, but you can do it without much hesitation. The other problem we see is cat and dog bites. I think most of the ER docs do pretty well at giving them the appropriate antibiotic, but the big lesson from my experience is if there's any question of a synovial sheath being penetrated by even a pinpoint cat bite, I believe you should make an incision and spread until you're into that joint or the tendon sheath, so you're not leaving any synovial space that's going to have fluid contaminated by bacteria, because inevitably you're going to get one of these pretty difficult to manage infections. So this is the same thing about suturing in a drain. Just a little strip, you just have to make sure that no fluid builds up and that you leave it in for a few days, at least until the signs of infection and the symptoms, the pain, is gone. The other issue that applies to all sorts of hand injuries is to understand the concept of position of safety. Now, I've listed some of the other joints there, but the most important one is probably the MCP joint, because that's arguably the single most important joint in the fingers. And 90 degrees, you'll never get 90 degrees in a splint, but you aim for 90 degrees. And the idea is that the position of safety is not a position of function. It's a position from which motion can be most easily recovered. It doesn't mean you necessarily want to immobilize them completely in that position. Ideally, you want the interphalangeal joints to be free to bend. So a volar splint that goes up to the distal palmar crease, and then a dorsal splint that goes at least to the PIP joint to hold those MCP joints down. The PIP joints tend to contract in flexion, and that's usually a bit later. The forearm position of safety is supination. Make sure they at least put their forearm into supination every day. Ankle 90, I think most people know that. It's not because of the tendon getting tightened. That's the misconception. And the knee 180. Anyway, just a couple of small things. In kids, something that can be missed is the Salter 1 fracture of the distal phalanx, because it reduces itself or someone reduces it. They come in, it looks normal, and the x-ray is normal, but it's an open fracture, and then they come back with osteomyelitis. So if there's any possibility, you got to really ask about the history and the mechanism. Just be aware of that. Central slip disruption is another one that's missed, because at the beginning, they can occur with very little bruising and swelling because the tendon doesn't have a lot of blood supply. It just tears off, avulsion, and they can still extend that joint. The problem is 6 weeks, 2 months later, they start losing the ability to extend the joint. And that's because so that point there represents the axis of rotation. The lateral band sits dorsal to that, and so it functions as an extensor. But if this tissue gets stretched by an imbalance that gradually progresses over time, then what happens is that shifts volar and you get a boutonniere deformity, because it no longer is capable of extending the joint actively. So if, as I ask all the medical students, the single most important thing in musculoskeletal exam usually is maximal point tenderness. So that's the real question you want to ask is there tenderness over the dorsum of that PIP joint? Because if there is, you have to assume that there is a tear and you have to deal with it accordingly. Another fracture that's commonly missed, even, well, I would just say, is base of the fifth metacarpal. It's the equivalent of a Bennett's fracture in the thumb, but the point is that on x-rays, it's often not very obvious, and you have to do a CT scan to see the articular displacement. The problem again is that they come back, you know, months later with a painful arthritis. And then you can't restore the articular surface because everything is all stuck in higgledy-piggledy configuration. I think that's it.
I think there's a chat question.
It doesn't
Yeah.
show on here.
No.
Okay.
Yeah, so I can actually read it to you if you want. It's, can Dr. Foster discuss Charcot foot briefly? Example, diagnosis and treatment?
Okay, that black boot that was in the picture, that is a Charcot boot. Basically, you have to immobilize the normal dynamic supports to the foot because they lose the sensory feedback. So they get collapse of the arch and they get tarsometatarsal breakdown. And that's where you need that full contact boot that is rigid. That's the only way you can really definitively manage it successfully. I mean, again, they have to inspect their foot every day very carefully. And again, using the back of your hand for neuropathic feet. They don't, well, often they're neuropathic with a skin sensation, but anyway, the back of your hand is usually the best way to look for warmth. Is that enough? Were there any other questions?
I'm not seeing any further questions. If anyone has any, they can unmute and ask.
Or comments?
Yes, do you have any comments about fiber or abscesses you would like to share?
So I make a big deal about preaching. So that's my other P, is the preaching. And to me, I think if you spend some time explaining how the fiber mediates the benefits, they're more likely to comply. So I always talk about stretch, and I call stretch the quarterback of gut muscle activity. And I emphasize that it's a completely separate nervous system from the rest of your body, the somatic nervous system. And I tell them, I just explain the range of bowel movements. So if it's too liquid and it rushes down, you get urgency and it's hard to hold it in. And then you have to go again 15 minutes later. If it's too hard and dry and it's not enough, it's coming down too slowly, then it comes once a week or even less frequently. And we see fecal impaction, and it's because it's coming too slowly and it doesn't generate a response in the rectum. The normal mechanism is when you wake up in the morning, your bowel empties the colon. It's often triggered by putting something into your stomach, a coffee or breakfast, and then you generate peristalsis that clears the colon into the rectum. And it is that stretching up of the rectum within a relatively short space of time, 15 to 30 minutes, that gives a very clear signal for the rectum that you got to defecate. And that is what helps the pelvic floor to relax. And we can talk about the two sphincters that have to relax. It's not just the circular sphincter, but it's the U-shaped flap valve sphincter. But when you explain this in a somewhat detailed, but I think simplified way, people get the idea. When you just sit down and let go and you have a nice big long log of form stool that pinches off, then that's a satisfying normal bowel movement. That's what you're aiming for. The fiber thing you know, some people don't need much, some people need more. You can't overdose on fiber. It's not a drug. And so I just tell them, do it until you get a lovely big long log of stool every day. And I think it's worth spending a bit of time, because a lot of people, they say, oh yeah, I'll take some fiber, and then they just give up on it. But if they really understand what's going on, they'll push through and experiment a bit and figure out what it takes for them to find success. That's probably enough preaching all there.
There you go.
I think
Takes
we're,
us to 1 o'clock, so I think we're good, but
no other comments?
no, it doesn't look like it. But certainly we're happy to answer questions anytime. We love talking about fiber and abscesses and goopy feet.
Okay, thank you.
Thank you both very much for presenting today.